Hello from Germany. My name is Greta Drews. I'm a respiratory physician in an OPD setting. I volunteer for an organization called Nepalmed, which has been supporting medical care in Nepal for 21 years. Despite the distance between us, we are all affected by COVID-19, and we would like to share experience of COVID-19 in Europe with health professionals in the middle of a wave in Nepal. Initially, the effects are acute medicine and sometimes it's post-COVID care.
We're very lucky in Nepalmed to have access to world-class medical experts, doctors, nurses, physiotherapists and scientists to provide information and knowledge and training and education around aspects of respiratory disease. And I'm delighted that we are able to introduce a range of speakers, some from the Queen Elizabeth Hospital in Birmingham and some from Nepal itself, to talk in these sessions about the issues of this pandemic.
Regarding the situation of intensive and respiratory care in Nepal, we are happy to welcome Dr. Sanjeet Shrestha. He works in Medicity Hospital in beautiful Lalitpur, and he is representative of the Nepalese Respiratory Society.
Namaste, I am Dr. Sanjeet Shrestha. I am currently working as a pulmonary critical care and sleep medicine specialist at Nepal Medicity Hospital, Lalitpur, Nepal. My job today is to talk about infections, hospitalizations, ICU uses and deaths in Nepal in last 1 year. Going by the daily updates on Nepal by Ministry of Health and Population, you can see that number of cases are rising. New cases are at the extent of 8,387. So most of the number at this particular point of time is above 8,000. And you can see deaths are always around more than 150. On the 25th of May 2021, the death recorded was 169. Because of these increasing number of deaths per day, total number of deaths in Nepal for the entire 1 year has increased drastically to 6,700 in the recent few weeks. If you go by the numbers provided by Ministry of Health and Population, you see that the entire Nepal's map is painted red, red indicating cases occurring more than 400 plus in a given district and province. If you go by the total recovered rate, you can see that 75 or so percentage of people are recovering nicely. At a given point of time, around 20 to 23% of people are infected, that is ongoing infection, and death rates are still less than 2%, but it's rapidly rising. Going back retrospectively into the course of pandemic, at the onset, first confirmed case in Nepal was identified on 23rd of January 2020. It was a student from Wuhan who returned to Nepal. There was a lag of 1 to 2 months before cases started to rise. Classes started to get suspended on mid-March 2020. Even academic exams were stopped. International flights were stopped on 22nd of March 2020. Even Visit Nepal program was cancelled. The first death in Nepal was recorded on 14th of May 2020. It was a postpartum lady from Sindupalcho, and the first local transmission was detected on 4th of April 2020, and it was from Kailali. A countrywide lockdown came into effect on 24th of March 2020 and ended after a very long time on 21st July 2020. Things were started to getting back to normal, but unfortunately, things started to get back to square one, and second lockdown was announced on 26th of April 2021, and it went into effect on 29th April 2021. As of now, the lockdown is being extended to end of May. This graph depicts the total number of daily new cases recorded in the last year in Nepal, and you can see that from May, June, July 2020. We had very few number of cases and was a fairly small hump in the pandemic. As things started to get heated up from end of July to August 2020, you can see cases started to rise gradually and it peaked in October, November. It was the season of Dasai and Tihar in Nepal at that particular point of time. And by the end of November, December, things started to get better and the first peak was over by the end of January 25th. Unfortunately, this season, from the April onwards, you can see there has been a great rise in number, and last year's peak and this year's peak is completely different as far as the severity is concerned, as far as the number of cases are concerned. If you go by the number of cases by province, you can see that Bagmati province has the highest recorded number of cases, and it is completely out of sync with the rest of the provinces in Nepal. This is because most of the cases are concentrated in Kathmandu, most of the population is concentrated in the valley, and most of the cases are being referred to Kathmandu. If you start counting total number of deaths per day in Nepal, you'll see that the graph will exactly represent the incidence graph. Last year's pandemic, we saw that there was gradual number of deaths and it didn't peak into highest recorded deaths. But this year, the pandemic is completely different. We have highest number of recorded cases and we have highest number of recorded deaths so far. Let us go through last week's total number of recorded deaths. On 15th of May 2021, 8,000 plus new cases were detected with 187 new deaths. On 16th of May 2021, 7,000 plus cases were detected with 145 new deaths. 17th of May 2021 and 19th of May 2021 were particularly worse. On 17th, more than 9,000 cases were detected with 240 new deaths. On 19th of May, more than 8,000 cases were detected with 246 new deaths, and the things are going on same line. And at this particular point of time, you can see that recorded number of deaths are still above 150 per day. We at Nepalmed City Hospital wrapped up our first peak data on 1st of March 2021, and we saw that October was the worst month for us. In the month of October, we recorded 1,654 positive cases, and in the month of November, we recorded 1,075 positive cases. In the last pandemic, we recorded total 16,159 total samples with positivity of 3,990 samples and negative of 12,169 cases. The peak month was definitely October for us, and the percentage positivity was highest in October with 32.9%. From the 1st of March to May 2021, at Nepalmed City Hospital, we have already sampled 16,159 samples. If you count per person, we have already sampled more than 12,000 people this year. Total positive samples are 3,406 and negative reports of 8,864. May is the month where highest number of positive reports and highest number of samples were recorded, and I hope this is the peak and things started to go better from this time onwards. We at Nepalmed City Hospital have a PHASIC transition protocol into COVID wards and COVID ICU. Last peak, we dedicated around 60 to 70 beds for COVID throughout the entire pandemic, and we gradually graded up to October and graded down till December, January. However, this year, this peak, we've already dedicated 123 beds for COVID. We're still counting and we're still adding. During the first peak, total patients at our COVID facility were 775 admissions with 661 ward cases and 114 ICU cases. We had total positive patients of 409 and total deaths of 43, and we used ECMO on one patient. There were patients who turned negative and died, and The number recorded was 16. We are still adding to this data because there are so many patients who died after turning negative, and some even died after returning home. During this ongoing second peak, the total patients at our COVID facility has already crossed 400 plus cases. 50% cases are right now ward cases and 50% are ICU cases. We've already admitted and only admitted all positive cases. Total deaths recorded so far, April and May, is 62 already, and we haven't used ECMO on any of these patients so far. Total number of patients who died after negative reports we're still counting, and we've already traced 5 or 6 of them till now. Before I end my presentation, I would like to state how we are doing as physicians in Nepal. After 1 year, we are back to square one. Number of cases are rising. We are exhausted yet compelled to keep working. Every pneumonia that we admit is turning out to be COVID pneumonia, and I wonder where did all other illnesses go. Most OPDs are now converted into virtual OPDs. Only OPD that runs is a fever clinic with 80-90 people coming into a single day OPD. Most patients that are getting admitted or turning out are severe patients and no beds are available. Question always rises whether we should send them home because there are no beds available. Because of this need, home-based guidances have been published, but still we are struggling. I would like to end my presentation with a colorful thank you. Though things are looking very bleak, let's hope future brings brighter things for us.
So we now have a picture of COVID in Nepal, the number of cases, the number of admissions, the number of ITU, and sadly the number of deaths. That's the official recording, and of course we all know that these numbers are probably not that accurate. But we're now going to invite our next speaker, who in some ways doesn't need a huge introduction, but pathophysiology is incredibly important to be able to understand how this disease has evolved.
We welcome now Professor Jonigk. He is a pathologist at Hannover Medical School in Germany. He traveled with me to Nepal in 2019 and gave several talks on his specialty in Patan Hospital, HAMS and other institutions. In 2020, he published very early in the pandemic a very important paper on the changes caused by the virus from the thoracic pathology point of view.
Ladies and gentlemen, dear colleagues, COVID-19 deciphering the pathology of a global pandemic. One needs to bear in mind that the lung actually is the only genuine life-limiting organ senescence-wise. At age 20, we have a functional gas exchange surface in the lung of about 100 square meters, as illustrated by Donald Trump's apartment here in New York. And at the age of 100, we statistically have a functional gas exchange surface of about 20 square meters, as nicely illustrated by this German prison cell. The infection with severe acute respiratory syndrome coronavirus 2, SARS-CoV-2, goes hand in hand with a very broad spectrum of clinical, primarily respiratory syndromes, which is obviously referred to as COVID-19. And especially in the lung, that ranges from mild upper airway symptoms to progressive and life-threatening viral pneumonia with labored breathing, progressive hypoxemia, and often mechanical ventilatory support becomes necessary. In CAT scan analysis, you find ground glass opacities in the lung, and together with the clinical findings, these fulfill the Berlin criteria for the ARDS, the acute respiratory distress syndrome. And the main histological hallmark of the early phase of ARDS is diffuse alveolar damage, as originally described by Katzenstein and colleagues, with hemorrhage, edema, and intraalveolar fibrin deposition. Of note, DAD is a very non-specific finding and can occur in a multitude of non-infectious and infectious causes, for example, the classical SARS-1, MERS, or the flu. This is an autopsy sample of a COVID-19 lung. You can tell how stiff and mucus-laden this is. And at the histological level, the histopathological level, you, as indicated by these arrows, very nicely see the accumulation of hyaline membranes, which are superimposed on the alveolar walls. As the main job of the lung is actually getting oxygen in and getting CO2 out, the enlargement, not enlargement, but the increasement of the diffusion distance by the factor of, let's say, 20 or 30 obviously impairs respiratory function. Aside of the fibrin and hyaline membranes, you also find a multitude of especially perivascular lymphocytic inflammatory cells. That looks a little bit like acute cellular rejection in lung transplanted patients. It's very angiocentric. And as I said, in COVID-19 and the flu, you have very, very comparable findings in regard to the morphological aspect. Not so much on the molecular level, though. Just broadly looking at regulated pathways and regulated genes in COVID-19 and influenza in the lung, you can tell that it's obviously very distinct on a molecular level. And as I said, the perivascular inflammation in the diffuse alveolar damage is very interesting to study the vascular aspect in COVID-19. Because formation of fibrin thrombi had at the time when we originally published in our New England Journal manuscript anecdotally observed but not studied systematically. We knew at the time, as obviously with the clinician, that elevated didimer levels, cutaneous changes suggested thrombotic microangiopathy, and obviously diffuse arteriovascular coagulation and large vessel thrombosis have been linked to multi-system organ failure. And this here is an autopsy specimen with the thrombosis in this intraparenchymal vessel. On the histological level, we have this small intrapulmonary vein, again, perivascular infiltrate of lymphocytes, and as marked by these asterisks, the very nice fresh thrombus in the vein. And 3D electron microscopy, here again, the thrombus is labeled in red, inflammatory cells in yellow, and you can see the hyaline membranes by this mesh-like material which is covering the insides of the alveolar. Formation of thrombi in COVID-19 and influenza lungs, when you really count it, you find that especially capillary microthrombi are more than 9 times as prevalent in COVID-19 as compared to the flu. And again, here indicated by the arrows. I mean, obviously there is no blood flow through these capillaries, and thus, again, in addition to the diffuse alveolar damage, the lung cannot properly function. When you now assess these samples by micro-CT, you find that in 3D reconstruction, it's not just that there is an impairment of blood flow, but the vessel itself is actually very affected. On the left-hand side, the controls, on the right-hand side, COVID-19 lung, and in red, the arteries. And that has to do that we are able to really trace endothelial infection and endothelial involvement and endothelial disruption with the presence of virus-like particles and the endothelium. You can also use fluorescence cytohybridization, immunohistochemistry. The virus is there. And the integrity of the blood-gas barrier is extremely important because the distinct interplay of the alveolar epithelium together with the blood vessels and of course the extracellular matrix is what allows the lung to function properly. And one has to keep in mind, these are 3D reconstruction preparations of cast materials, so actually injection of special resin into the vessels, and then after it has hardened, digestion of the biological tissue around it. And in the liver, the lung, the skeletal muscle, or in this endoneuroplexus, you have very distinct patterns of vasculature which are very specific for the organ. And without going too much into detail, you have a very distinct form of blood vessel neoformation by intussusception. On the left-hand side, you see the control. This is how the capillaries look in the alveolar wall. And on the right-hand side, this is COVID-19. And in panel C, you can see these donut-shaped openings, which is the morphological hallmark of intussusception, whereas sprouting angiogenesis is for example, cancer-associated wound healing is the associated process that we know very well, it takes days to weeks. Intussusceptive angiogenesis takes place within minutes to hours. It's very dynamic by the incorporation of progenitor cells. And when you actually count that, you can find, well, yes, there is intussusception in the flu. But when you see, when you actually assess intussusception in COVID-19 lungs, it's much more prevalent, and it really rises the longer the patient is hospitalized. And again, the molecular regulation of angiogenesis in COVID-19 and the flu is totally different. And the very same is true for most visceral organs. COVID-19 is an angiocentric multi-organ disease, and the clinical presentation depends on the function and the vasculature of the arterial, capillary, and venous network in a given organ. Now, where we're taking this together with the ESRF and the UCL, especially Paul Tuffereau, Peter Lee, and Claire Wall shall be mentioned here, we are using synchrotron imaging for 3D reconstruction of affected organs. And for the very first time, we are able to really assess completely intact human lungs, human COVID lungs, in 3D reconstruction down to 25 micrometer voxel size. And that allows us to really assess changes of the vasculature of the airways and their interplay in a totally unprecedented manner. This is really going to open the door to a new field of pulmonary pathology. And together with our established techniques, we were able to demonstrate, based on our synchrotron imaging, that excessive blood clotting, massive blood vessel damage, and new vessel formation via the intussusceptive angiogenesis is what's accounting for the massive damage and the high mortality when you have advanced COVID in the lung. We're taking this forward. Again, it was not me who did these experiments, but our very active research group, lots of our collaborative partners, our techs, and of course the institution who are funding our research. I thank all of those. I thank you very much for your attention, and I look forward to answering any question which might occur.